Thanks a lot. So we know all that trauma brain injury is a devastating condition, and it's associated with substantial mortality and lifelong disability. So what is the role of the neurosurgeon in the management of this patient? What is the place of the surgery? Just to illustrate this, this study, it's a randomized control study. It's a study about the effect of erythropoietin in trauma brain injury. And I want to show you this study because it's a study which was performed in Australia, New Zealand, France, Germany, Finland, Ireland, and Saudi Arabia. So it's interesting to see in this different country the incidence of surgical procedure in trauma brain injury. In these studies, they consider moderate and severe trauma brain injury. And you can see that it was mainly severe trauma injury because there is around more than 70% of severe brain injury. And concerning surgical intervention, you can see that it's in around 30% of the case, patient need surgical intervention. So it's a great percentage of case. And because most of the time, if we consider all the trauma brain injury, most of the time we think that the neurosurgeon very exceptionally had to perform an intervention. And it's not true if you consider moderate and severe trauma brain injury. And you can see that in this study, looking at decompressive craniectomy, we had between 2 and 5, depending on the group, percent of decompressive craniectomy in this patient. And it was great because this patient clearly was monitor with an ICP monitoring. So concerning the outcome, if we look at the extended Glasgow outcome scale score, and we consider that stage 1, 2, 3, and 4 are bad recovery, you can see that we have 45% of the patient with dead or vegetative status or severe disability. 45. Keep this percentage in mind. So at the admission of the patient, it's very important to have a good relationship with your neurosurgeon and to talk with him about do we have to go for surgery. And there is a precise criteria to perform surgery, or it's the so, for example, for acute extradural hematoma, it's a volume greater than 30 cube centimeters on the CT scan, and I don't want to go through all the indication, but it's important to have this in mind during your discussion with the neurosurgeon. If there is no surgical indication, we will start for a medical treatment, trying to control the intracranial pressure, and it's important to be ready to perform serial imaging, and the crucial point is to have a close monitoring. So we have to monitor ICP, and it's highly recommended. And we have to be concerned about trying to have a cerebral perfusion pressure within the range of 50 to 70 millimeters of mercury. And I think that 70 is more appropriate to have a margin of security concerning brain oxygenation. Transcranial Doppler could be very also useful. And you know that we usually work with the pulsatility index, and we consider that when we have a pulsatility index greater than 1.2, it could be due to an increase in the intracranial pressure. And you know, it's very important to deal with each monitor, because if we have a doubt about your intracranial pressure and your Doppler is altered with an increase of the pulsatility index, so you know that your intracranial pressure is not is not correct, and you can redo a CT scan just to be sure. So it's very important to use all the monitors that we have. And also more and more we test the brain oxygenation with the brain tissue PO2. And we consider that when we have a brain tissue PO2 lower than 20 millimeters of mercury, it's potentially we have a brain hypoxia, and we have to do something. And to highlight this, and it's a study where they consider all the study where the treatment was based on ICP and on CPP, or was based on ICP, CPP, and the tissue PO2. And you can see that considering this and considering the favorable outcome, you can see that when you use ICP plus tissue PO2, you have a more favorable outcome. So I think it's as to push us to have this multinodal monitoring. NIRS, so we have not enough study, and it's not possible to recommend NIRS right now. So we know that to deal with intracranial pressure, we have to maintain and to prevent secondary brain injury. You have to maintain CPP. We have to prevent hypoxemia, prevent anemia. We have to control the capnia. It's a crucial point. And prevent hyponatremia, control the glycemia, and treat fever. But if we have, despite this, an increase in intracranial pressure in ICU, what we have to do? The first thing is to recall the neurosurgeon. And at the end, it will be really a good friend. Be sure of this, because if you stimulate him constantly, he will become your friend. Or I hope. Yes, it's so important for the patient to have plenty of friends in the hospital. So no, it's true. Think of this. So the first thing is to know if we need to go to the operating room and to reconsider this. And most of the time we have to redo a CT scan. But if the CT scan is unchanged, so we are going to control the ICP by medical treatment. And there is different step. Step one is to check the CPP, PO2, CO2, natremie, and to consider the head elevation, to consider sedation, ventilation, analgesia, to consider an anticonvulsant therapy, and also to monitor not only the brain, but also to monitor the systemic circulation to know if there is an hypovolemia, and to be sure that there is no impact on the brain circulation. And if despite this you have still an increase in intracranial pressure, you have to consider ventriculostomy, you have to consider mannitol, hypertonic saline, hyponatremia, with neuromuscular blockade. It's very important to go step by step to control your intracranial pressure. So if everything fails, you have to once again talk with your neurosurgeon and ask him if we have to do a decompressive craniectomy. So there is two control study about this. The first one is for Jimmy Cooper, and they test this in 155 patients, and they define refractory intracranial pressure by spontaneous increase in ICP greater than 20 millimeters of mercury for more than 15 minutes. And you can see that on the graph that when you perform the craniectomy, you have a nice decrease in ICP, but it was the goal. But what is interesting in this study is that in the control group, the ICP was around 20, not so increased, not so uncontrolled. So the question is the craniectomy really necessary in these patients? And another problem in this study is that 15 patients in the standard group underwent daily decompressive craniectomy as a life-saving intervention. And in 4 patients in the standard group, craniectomy was performed contrary to the protocol. So it's introduced bias in the study, in my mind. But the results are, they observe that there is more number of episodes of intracranial pressure in the group, in the standard group. And they observe a decrease in the day of mechanical ventilation and a decrease in the day of ICU stay. And but about the outcome, there was a worse outcome when they perform the decompressive craniectomy. Unfavorable outcome, it was 70% in the craniectomy group, so a huge one. But once again, in this study, a limit of the study is that it's not a limit, but it's we have to consider this. After post-hoc adjustment for pupil reactivity at baseline, there was no difference between the two strategies. But clearly, there is no advantage to perform craniectomy. And in the decompressive craniectomy group, there is more complication, and especially hematoma, cerebrospinal fluid leak, and hydrocephalus. Another study is from Hutchinson, and it's a study where they consider a refractory increase in intracranial pressure. It was greater than 25 for 1 to 2 hours. And this criteria seems more appropriate for what we know in ICU dealing with trauma brain injury. So the two groups were comparable. And in terms of recovery, you can see that there is, when they perform surgery, it was associated with a higher rate of vegetative state and severe disability than medical management. And the rate of moderate disability and good recovery were similar in the two groups. Once again, there is a limit in the study. One of the limits is that decompressive craniectomy was performed in 37% of the patient in the medical group. And the other thing is that when we observe the rate of unfavorable outcome in medical group, and if I compare to the study about the erythropoietin study, it was a very, very, very high rate of unfavorable outcome. So maybe, I don't know why, but it's surprising, and maybe it has an impact on the result. So to conclude, surgery, neurosurgeons are very important when you work in ICU dealing with trauma brain injury. And considering craniectomy, decompressive craniectomy, right now I think it's very difficult to do this systematically, and we have to consider case by case, and it's very important to work with your neurosurgeon. Another problem, I think a very important problem, is the communication with the family. Information to the family, information about the outcome of trauma brain injury, for sure, but if you perform a decompressive craniectomy, you have not to give too much hope to the family, and you have to try to have the more rigorous and fair information about this. Thanks a lot.